Oh, my name is Michelle Cicel, and welcome to the course. I'm going to be presenting this module through medical professionals. Today, we'll be discussing malignant and high-risk breast lesions. All right, let's get started. All right. So this is the outline of what we'll be talking about. So we'll go through each one of these one at a time, all the way to the end. Depending on time, hopefully we'll get to the case studies. Otherwise, you will have the option to look at them afterwards. So just so you get familiar, this is the ACR American College of Radiology BIRADS Atlas, and it's the 5th edition. This is a quick reference guide that our radiologists use as a tool when they are reading their mammography, ultrasound, and MRI exams. This is also something that becomes very useful for us as the technologists to use when we are learning and speaking to our radiologists about benign or suspicious lesions. Keeping in mind, mammography is the gold standard. And when we say gold standard, we mean that this is the number one best technology out there still that we are saying to have the patient do for screening mammography. Radiologists then use that ACR BIRADS Atlas to read and make a report. And then they characterize the lesion according to how it looks. Is it a mass? Is it calcifications? Is there an asymmetry? Then they use additional imaging if needed for further confirmation what they are looking at. Or they might just say everything looks good and give them a BIRADS 1 or a BIRADS 2. When we do see a new area on a mammogram, this is that quick reference guide that you see off to the left. So they are looking at the breast composition. They're looking at, is it a mass? If it's a mass, then does it have a shape that they can describe, the margins, and the density of that mass? If they think it's calcifications, then they're going to call it typically benign, and they'll go into more detail, or they'll say suspicious morphology and go into more detail, or the distribution, or I should say the distribution. Is it diffuse? Regional groups of calcifications? Are they linear? All of this helps the radiologist to decide and to categorize how suspicious these areas that they're looking at are. And then architectural distortion. This is for asymmetries that they see either on one or both of that screening views. And so they can describe it as an asymmetry, global asymmetry, focal asymmetry, or a developing asymmetry. When we do ultrasound, there's also a quick guide or a quick reference in the ACR BIRADS manual. So our job as the breast sonographer is to describe to the radiologist what we see. So we want to be looking for different things like we see over here. If it's a mass, we still also want to describe it with one of these different vocabulary words or even more descriptive words here. So if we feel that we see a lesion that is round, oval, or irregular, we want to be sure to describe that to the radiologist. What is the orientation of that lesion? Is it parallel to the skin or not parallel? Does it have little fingers coming off of it? The margins, is it circumscribed? Could you take a pencil and draw all the way around it and say, I see all of those borders? Or is it not, or partially circumscribed? The echo pattern. This one's very important that as the sonographer, you start to get used to using these words. And I know at first it's very hard to get used to it when you really don't understand it. So try to use it, maybe talk to your radiologist, say, is that the correct way to use this term? And that's how you'll become more comfortable. So echo patterns such as anechoic, meaning that it's black, there is no echoes within it. Hypo or hyperechoic. Hypo is that it is darker grays than the surrounding fat tissue, or hyper, brighter echoes within the lesion compared to the surrounding tissue. Isoechoic. Isoechoic means it's very similar. You see this a lot with lymph nodes or benign lymph nodes, or it can be a mixture of all of these or a couple of these. Posterior features, another big one that the radiologist would really like you to describe to them, or at least get good images of. And that would mean, is it posterior enhancement? Is it brighter behind it? Or is it a posterior shadow? That means it's got that shadow, that dark area behind it. Or is there none? There isn't a posterior feature to describe. Optimal imaging can change what our recommendations to the patient will be. So that's why it's on us to make sure we get good images and that we take the time to describe what we see, what our impression of our images to the radiologist. Breast anatomy, we won't go too deep into this, but you do know that there's muscle and fat and lobes and ducts all the way to the areola. We are describing all these areas. We're seeing them on our images, and different cancers are found in different areas of the breast, which we'll go through. So when epithelial cells transform to malignancy, but do not extend past the basement membrane into the stroma or the fatty tissue. So here you've got your duct. So you have your duct here with the basement membrane here. That would be a breast cancer that is non-invasive, or it's called in situ. So once the cells break through the basement wall, as you can see on this far image, that's that basement membrane. Now they are breaking out these malignant cells. Then it's called an invasive cancer. A little bit about calcifications. So these are best seen mammographically. There aren't going to be many times that a radiologist asks you as the sonographer to go find something that is a group of calcifications unless it's within a solid lesion or something that looks like might be solid with that grouping. So there are three categories with these different calcifications, typically benign, which would be BIRADS 3, short-term follow-up, suspicious, BIRADS 4, consider biopsy, and then the distribution of them. We want to know what the different distribution is. If it's not associated with mass, it probably will not go to ultrasound. If we do decide to biopsy it, usually it will be biopsied under stereotactic or mammography guidance or tomo guidance, which is 3D guidance. Characteristics are important. Ultrasound, if we do ultrasound, there may be some shadowing. And again, that's if there's some darker, more grouped calcifications together, that will cause there to be a shadow, and that will be helpful for you to see. So it doesn't mean we will never be looking for calcifications under ultrasound, but if there are times you may see shadowing in there. Next, we're going to talk about high-risk breast lesions. So we will talk about each one of these. So the first two lesions are examples of hyperplasia. Hyperplasia is an overgrowth of the cells in the lining of the lobules, the milk-producing glands, or the ducts, the tubes that transport the milk. A diagnosis of hyperplasia is not a diagnosis of breast cancer. It's a diagnosis that increases the risk of breast cancer. There are two different diagnoses of hyperplasia at the cellular level, usual or atypical. So here would be usual, and then you can see it's starting to look a lot more atypical, a lot more concerning. Usual means there is an overgrowth of cells, but the cells still appear to be normal. Atypical hyperplasia also has an overgrowth of cells, but the appearance of the individual cells are abnormal. Atypical ductal hyperplasia and atypical lobular hyperplasia are the lesions we put in the high-risk category and usually treat with surgical removal. Atypical ductal hyperplasia is also ADH. This is a benign high-risk lesion, as we just discussed. It is located in the terminal duct lobular unit, so the TDLU. Here you can see this image, and it's showing you the TDLU. The image picture shows the TDLU and all the encompassing parts of the TDLU. ADH has features similar to low-grade DCIS when looking at the cellular components. It is usually an incidental finding when performing a biopsy on another suspicious area. ADH is recommended to be surgically excised because it carries increased risk of developing an invasive breast cancer. Mammographic findings of ADH is usually found incidentally. It can be associated with calcifications described as amorphous and with a clustered or grouped distribution. It can also be found with punctate or pleomorphic fine linear calcifications, such as the ones that you are seeing in this image. Ultrasound findings for ADH. Here's a solid lesion that was seen under ultrasound. Because of its characteristics, longer than it is wide and unclear margins, the radiologist recommended a biopsy. And the pathology came back as a fibroadenoma with atypical ductal hyperplasia. So again, this is one of those that usually is found once something is biopsied. And then we talk about atypical lobular hyperplasia, or ALH. This is a benign, high-risk lesion with abnormal overgrowth of cells in the lining of the lobes. ALH has also features similar to low-grade DCIS, and it typically is found in biopsies of another suspicious finding, such as amorphous calcifications, just as we talked about before. Because of the increased risk of developing breast cancer, again, surgical excision is recommended. This was a case where the radiologist saw a new suspicious amorphous group of calcifications. The recommendation was for stereotactic biopsy or guidance under mammography, and the calcifications were seen in the upper outer quadrant. Here you can see. The patient was referred to the surgical team for a lumpectomy of the area. After the lumpectomy, patient would return to their normal screening schedule as long as the specimen was not upgraded to a ductal carcinoma in situ or DCIS after excision. Here's a case where the sonographer and radiologist could see a hypoechoic area with posterior shadowing. So here you can see that. That's that posterior shadowing. Multiple passes were taken and the specimen was sent to pathology. Pathology came back as ALH, or the atypical lobular hyperplasia, 48 hours later. The patient then had a lumpectomy to remove the lesion and the surrounding tissue. When the final pathology from the lumpectomy came back, the pathologist had upgraded the specimen to a low-grade DCIS, and hence the reason we suggest or recommend surgical excision. LCIS is similar to atypical lobular hyperplasia. Both have an increased amount of abnormal cell growth and are contained within the lobules of the breast. The difference between ALH and LCIS is that there are more abnormal cells in LCIS. LCIS is not a cancer, even though it says lobular carcinoma in situ. So that was one of those that it took me a while to understand. It's actually a high risk breast lesion, but it's benign. LCIS is more common in premenopausal women and is usually not seen on a mammogram. It is rarely imaged as a mass or has any calcifications involved. Surgical excision is again recommended with the possibility of an upgrade to some type of cancer's diagnosis after excision. So when you look at the image, you can see a sagittal view of the breast. The lobules are the small bumps that make up the lobes. So the smaller little bumps make up the lobes. From the lobes, there are ductal canals that lead out of the individual lobes that are led out towards the nipple. You can see the normal lobe with the individual. It's a grape-like normal cellular lining. The next image shows overgrowth and abnormal cells filling the lobules and lobes, but still contained within the outer membrane. LCIS is typically an incidental finding. Amorphous calcifications are usually the target of the biopsy. A pathology report of LCIS means the patient has an increased risk of invasive malignancies in the future. LCIS is frequently found to be multicentric, which we'll talk a little bit about, or in more than one quadrant, and it can be bilateral. It is not a cancer diagnosis again, but many feel it could be a precursor as an invasive diagnosis. So again, surgical removal is recommended. If the patient is not a surgical candidate or we prefer not to have surgery, a diagnostic mammogram can be ordered at a shorter interval than annually, and the patient could begin an anti-estrogen drug such as tamoxifen. Tamoxifen is a known drug to help reduce the risk of certain breast malignancies and is used in many high-risk patients. So even if they've never been diagnosed with breast cancer, if they have a high risk of it, or if they have family history, tamoxifen is one of those anti-estrogen drugs that they may put the patient on. Here's a mammogram of the patient who came in for her annual mammogram. Both 2D and 3D mammograms were obtained. The patient's breast density is category B, which is that scattered fibroglandular tissue throughout the breast. The best technology in mammography for breast density is that 3D mammography or digital breast tomosynthesis. 3D image slices through the breast tissue from side to side. In the image here, we're going to show you that far right, this is a 3D slice. So just one slice out of that 3D exam. The right CC is from the superior portion of the breast to the inferior. So it starts superior and it goes inferior. In the 3D slice on the lateral side of the nipple, there is the suggestion, this is the lateral side of the nipple, there is a suggestion of architectural distortion with amorphous calcifications, which we're not really able to see. Both these findings are suspicious for cancer, so the radiologist decided that we needed further workup. So the patient did have an ultrasound, and because of that architectural distortion, and because on that 3D slice, we were able to tell that it was on the lateral edge. So we were able to kind of scan on that whole lateral side. If you're looking at a 3D slice in particular, you should be able to tell, as long as the nipple's in profile, if it's on the upper or the lower half of the breast on that 3D slice. So this one in particular was on the lower portion of that 3D slices on the CC view. So now we knew it was on the outer and we knew it was lower, so outer lower quadrant. When we were scanning, we found it at the 5 o'clock, 3 cm from the nipple. The area could be described as irregular, so the margins are not perfectly drawable, with posterior shadowing, and we had that in both planes. The lesion, when measured, was taller than it was wider. And so therefore, this put that into that suspicious category. The radiologist decided to recommend a biopsy. The biopsy was performed and the pathology came back as LCIS, Lobular Carcinoma in Situ. The patient decided to have the area excised, and the final report did remain to be LCIS. This patient was then recommended to go back to her normal annual screening. Now, again, when we talked about that tamoxifen, on the clinical side of it, her primary care physician might decide to put her on some type of anti-estrogen drug, depending on her age. The next one is a papilloma with atypia. So if a biopsy comes back as a papilloma, as long as there is no atypia associated, it's considered a benign lesion. So you can get a pathology back that says, yes, it's a papilloma, but with no atypia means it's completely benign. When it has atypia, that puts it in a little bit more suspicious category. So most facilities will even recommend a surgical excision if it is benign for fear of upgrade post-surgical excision. So papilloma, mammographically or sonographically, may not have any imaging features to differentiate it between whether it is benign with atypia or malignant, hence the reason for excision. Patients with bloody nipple discharge in a single dilated duct would have concern for a small papilloma. If a solid lesion is suspected, the sonographer must always turn power or color, so whichever one in your facility you're used to using on, and turn it on to look for blood flow in the lesion or a fibrovascular stalk, as you can see here. Make sure you're using very light transducer pressure. This is necessary, and it also is necessary to be patient. These are very, very small vessels if we do have some type of vascularity going into the solid lesion. So that will help us to get that blood flow if you're light compression and holding still with patients. So on this mammogram, the radiologist described finding a new circumscribed or obscured mass. It looks like there may be a solitary dilated duct on ultrasound. A helpful but not as widely used procedure was this one, which is called a galactogram. Now, this is not as widely used in the United States. In other countries, it might be still used. It is a very helpful type of exam. The only problem is once you are injecting that dye into that solitary duct that we think the blood is coming from, if that duct ruptures or that contrast extravagates with into the breast tissue, we no longer have the ability to diagnose off of it. So that is why a lot of places in the United States have gone to MRI. So an MRI for patients with bloody spontaneous, that's usually important too, bloody nipple discharge, will be the next step if they have a negative mammogram and ultrasound. So here's a 34-year-old patient who experienced left unilateral one-side bloody nipple discharge for 1 month. The patient described seeing a few dots of red on her nightgown a month ago, but it had gone away. A few weeks later, she felt something wet on her nightgown and looked down to see a slightly larger spot of red. The patient had an ultrasound and the finding described as a solid oval mass thought to be seen within a duct. And so that is important. If we can get it to follow to a duct, sometimes you're not able to do that. So because of this, the patient did go under biopsy and it did come back as a papilloma, and it came back as a papilloma with atypia. Radial scar is the next one. It's also known as radial sclerosing lesion. This is another lesion that's usually not palpable and seen on a mammogram, presenting as possible spiculation or architectural distortion. On ultrasound, the lesion can present as an irregular hypoechoic mass with spiculations. On MRI, it can present as an enhancing irregular mass. On all of these modalities, it can mimic cancer and needs further workup. Approximately 30% of cases of radial scar with atypia are associated with ductal carcinoma in situ, so DCIS, or tubular carcinoma. Therefore, they are usually surgically excised, especially if they are associated with ADH, ALH, or LCIS. Here's a 70-year-old patient that came in for her annual mammogram. She was called for additional workup after a closer look at her 2D and her 3D mammogram. On the 2D images, the lateral superior and posterior, so lateral would be here, superior, and then of course they're both posterior, looked more dense, similar to the LCIS case we looked at earlier. So then they looked at the 3D exam and it had more information. On the 3D tomosynthesis slices, the area definitely holds up and has more irregular margins. Ultrasound findings show a hypoechoic, and it has irregular margins. The lesion is longer than it is wide, so it is taller. That's a better word, taller than it is wide. And it seems to be disrupting the planes of the breast tissue. That's another thing that's very interesting to look at. If it looks like it's breaking through, causing a disruption of any tissue that should be continuously going horizontally, that's another thing that's concerning. So when correlating the finding under ultrasound, we can say this lesion on the mammogram is in the whiter, denser area of the breast tissue in the upper outer quadrant. On ultrasound, the sonographer documented the lesion at about 130. Now, you may not use 30s in your practice. You might just be 1, 2, 3, 4, 5. That is fine. Some practices do the 30. So 130, approximately 6 cm from the nipple. This hypoechoic lesion is also within that whiter, dense tissue as per the mammogram. So here it was in whiter, denser tissue, and here it is in that whiter, denser tissue. So therefore, we felt that this was a good correlation of the area documented between the two modalities. The lesion was biopsied, and it came back as a benign radial scar. All right. So now we're going to move on to our malignant neoplasms. That was our high risk. So this first one is ductal carcinoma in situ, or DCIS. This is the most common non-invasive type of cancer. It is the second most common breast cancer in general. So this is, let me re-say that, the most common non-invasive type of breast cancer. It's the second most common type of breast cancer overall. So let's review the images. First is the normal duct. It has an inner layer with normal ductal epithelial cells. That's what this is. And then when we get to ductal hyperplasia, we're starting to get a few more layers, but they are looking still normal. We go to atypical. We have those layers, plus we have those abnormal layers starting to grow. And then we get to DCIS, where it's showing that we are going to be having some epithelial cells in the canal that are definitely abnormal in shape and have multiplied to a point that it is now considered a cancer. And then lastly, we have that invasive ductal carcinoma, IDC, where the abnormal epithelial cells have broken through the basement membrane of the duct and are spreading to surrounding tissue or even organs. So DCIS, there's two types of DCIS. One is considered low grade and is called non-comedo. The other is considered high grade and it's called comedo. Non-comedo DCIS accounts for approximately 40% of all DCIS cases. This type of DCIS is slow growing and is considered less aggressive. Comedo DCIS accounts for approximately 60% of all DCIS cases. This type of ductal carcinoma is, this type of ductal cancer is considered aggressive. So for mammographic findings, mammography is the best screening tool we have for DCIS. Mammographically, the radiologist will describe new or an increasing number of microcalcifications. Remember, we discussed earlier the characteristics of calcifications, such as the morphology and the distribution. This all determines the suspicion level. Sonographically, calcifications cannot be seen unless they are large, within a solid mass, or are causing shadowing, which may occur when they're in a tight group pattern like you see in this image. Calcifications are usually not sent to ultrasound for further workup, but if the radiologist feels there may be a solid component associated with that calcification group, ultrasound may be ordered. Architectural distortion is a common finding, even if a mass is not definable. You might also find dilated ducts with shadowing caused by these calcifications within the duct. A mass in the duct may be seen similar to what we talked about for a papilloma. Invasive ductal carcinoma, or IDC. Invasive ductal carcinoma can also be called infiltrating carcinoma, represents breast cancers that have malignant extensions beyond the basement membrane of the ductal canal. Invasive ductal carcinoma is the most common type of breast cancer, and it accounts for 60 to 65% of the diagnosed breast cancers. So here on mammography, invasive ductal carcinoma represented by irregular spiculated masses, sometimes with microcalcifications involved. Here you can see this one is irregular. It is larger. It's highly radiopaque, so that means it's seen really well on mammogram. Here under ultrasound is the same image we just looked at, but under ultrasound, this lesion is ill-defined, taller than wider. So again, taller than wider. That would be on this one here where you can see these two. It is disrupting the fascia or the layers of the tissue going through. And it has that irregular margins that you can't take a pencil and draw a nice, smooth line around it. It also has some vascularity within the lesion. Other descriptive vocabulary that you might want to use when describing it, a solid lesion that is hypoechoic compared to the surrounding fat. It's heterogeneous in the overall echo texture. So this is just describing these different areas. These are both malignancies. Shows shadowing. This one not in particular doesn't have any shadowing. So here you would say there is no shadowing. But if it does, make sure you're mentioning that. You'll mention if it's in the ducts or extending or branching patterns. If there's angular margins seen, consider that all of this is considered highly suggestive of malignancy. And this will help your radiologist decide if more workup is necessary or is it time to go straight to biopsy. Some less common malignant IDCs would be medullary, papillary, mucinous or colloid, and tubular. These are also found, can be seen as new lesions, masses, or asymmetries on mammogram, just as we discussed with the more common ones, and would have the same appearance that we just discussed about the previous category. This may include a solid mass, shadowing, irregular margins, etc. The recommendation would be the same as any other lesion considered a BIRADS 4. It is a suspicious lesion and a tissue diagnosis is recommended. When pathology comes back with a diagnosis of IDC, that may include specific ones or that we just talked about or more uncommon variant features such as the papillary that we have just talked about, those 4 uncommon. The variants account for approximately 2% of all breast cancers, so they aren't seen very often. In this patient's mammogram, a new asymmetry was seen on both the CC and the MLO. The patient was called back for additional workup. When the patient returned, the technologist performed spot views on both the CC and the MLO, with the asymmetry holding up and still visible. On ultrasound, the lesion was small, hypoechoic. It is ill-defined, and it was questionable whether it was solid versus cystic because of the size. Therefore, the interpreting radiologist recommended a BIRADS 4, classifying the lesion as suspicious and recommending that tissue should be taken for sampling. Pathology came back, and it was positive for IDC with papillary features. As you can see, only pathology can determine whether variants are present. Before we discuss the common and uncommon ductal carcinomas, now we're going to talk about the common and uncommon breast tumors that are in the lobes or the lobules of the breast. And that'll be each of these that we'll talk about. So invasive lobular carcinoma, or ILC, is sometimes called invasive mammary carcinoma. With invasive lobular carcinoma, we are talking about epithelial cells that are malignant and are now invading the outer membrane of the lobule. So it's just like with the duct, it was invading outside the duct. Now we have a lobule, it's invading outside the lobule. Remember we talked about LCIS or lobular carcinoma in situ. That is when the lobular cells are still contained with the lobule or lobe. Once they invade the outer membrane, they can now spread outside the lobe and to other tissue or to other organs. Invasive lobular carcinoma accounts for 8 to 15% of breast cancers, and it is the second most common type of invasive breast cancer. ILC is the most frequently missed type of lesion because it can be mammographically occult. Usually ILC is not palpable and it may not produce any architectural distortion in mammograms. Typically, it does not have microcalcifications associated with it, but it is highly infiltrative and is more likely to be multifocal, multicentric, and bilateral when compared to IDC or invasive ductal carcinoma. This was a patient who was afraid to come in. We see this a lot with patients. They will often say they felt a lump but were too worried to come in and hoping it would just go away. So while invasive lobular carcinoma is rarely seen on a mammogram in its early stages, in the later stages, as you can see with this patient, there are spiculated areas bilaterally, areas of ill-defined lesions, radiopaque areas, and it is invasive bilateral. In most cases, ultrasound may be even more effective than mammography. Areas seen under ultrasound may be hypoechoic, irregular, ill-defined, vascular, and may extend beyond a single quadrant or even to the other breast. Next is Paget's disease. Paget's disease is a rare breast cancer seen in approximately 1% of the population. This type of cancer begins in lactiferous ducts and it travels to the skin of the nipple and areola. The skin of the nipple and areola may appear crusted, scaly, and red. Patients may complain of itching, which can also lead to ulcerations and erosion of the skin around the nipple and areola. 50% of patients will complain of a palpable mass in the subareolar region. The finding is usually unilateral, and 95% of patients will also have an underlying carcinoma, such as DCIS. This is a 67-year-old female patient complaining of a rash that began near the nipple and was itchy. She tried putting a triple antibiotic and an anti-itch cream on for a few weeks, but finally decided to see her primary care physician when she realized the rash was getting worse. Her physician immediately was concerned about Paget's disease and she was sent for a mammogram. The patient's mammogram came back negative, so she was sent to dermatology to have a skin punch biopsy. The punch biopsy came back positive for Paget's disease, and therefore the patient was sent for an MRI of the breast to further evaluate both sides. You can see the patient's nipple and areola skin appears crusted, scaly, and red. Although mammographically Paget's disease can be occult, in later stages the affected breast can be larger, less compressible, and denser mammographically. It may also have trabecular skin thickening. Here's a 32-year-old female who presented with a firm right breast mass and bloody nipple discharge. On the right, this medial lateral oblique mammogram shows a new area of density with pleomorphic segmental microcalcifications. Pathology came back as Paget's disease with ductal carcinoma in situ comitotype, which is the more aggressive breast cancers. Inflammatory breast cancer, or IBC, is another rare type of breast cancer, and it accounts for less than 1% of diagnosed breast cancers. Patients complain of an enlarged breast that is tender and firm. They may feel that the breast is warm and have an appearance similar to an orange peel. This is called peau d'orange and is a sign of edema or fluid in the skin of the breast. Peau d'orange is also a symptom of acute mastitis, and it can be difficult to differentiate between the two without further workup. Inflammatory breast cancer is an aggressive disease with a poor prognosis if not found early. Most patients will die within 2 years of diagnosis, and the survival rate is 10%. IBC invades lymph vessels of the breast, causing edema or peau d'orange in the skin. A discrete palpable mass may not be present. This is an example of a patient who was diagnosed with inflammatory breast cancer and had a mammogram. The interpreting radiologist reported thickened skin and increased density when compared to other areas of the breast in prior studies. Inflammatory breast cancer under ultrasound can have mixed echogenicity. You'll see that thickened skin. So remember, right in here is where you would be measuring. Edema or fluid in the skin and in the tissue. So here you can see some fluid pockets within here. Next is Phyllodes Sarcoma or Cystosarcoma. This is another rare breast cancer. The difference with this type of cancer is that the cancer cells are in the connective tissue and not in the epithelial cells, as we've seen in previous diseases. This type of breast cancer grows rapidly. It can be felt as a firm nodule that may get so large it bulges and stretches the skin to the point of discoloration or ulceration. Benign phyllodes tumors share the same characteristics. The only way to tell which is present is by sampling the mass. Phyllodes Cystosarcoma. Here you can see it mammographically. A phyllodes tumor can be a solid mass with well-circumscribed margins. It can have smooth lobulated or multilobulated margins. That's what you're seeing here. Let me see. I see a question popped up. Let me see if we're not too far ahead. What's the difference between cancer and carcinoma? That's a great question. They mean the same thing. So a carcinoma is essentially saying cancer. Now I know that when we were describing some of these, we'd say lobular in situ carcinoma or lobular carcinoma, invasive carcinoma. Essentially, carcinoma and cancer mean the same thing. All right, lymphoma. Make sure that was the only one. Okay, good. All right, lymphoma. This is less than 1% of breast cancers, and they are primary lymphomas. Primary lymphomas originate within the breast and or originate within the breast and or regional lymph nodes. There's also something called secondary lymphoma, and this is more common, and it arises elsewhere in the body, then it metastasizes to the breast. Lymphoma may be present mammographically as a palpable mass or palpable lymph nodes in the axillary region. 10% of patients will present with night sweats, fever, and unexplained weight loss. Some will be hormone positive for estrogen or progesterone. And we'll talk a little bit more about estrogen and progesterone receptors in a bit. Primary breast lymphoma is typically a B cell type of non-Hodgkin lymphoma. Rarely it can be associated to breast implants and the autoimmune disease BIALCL, or breast implant anaplastic large cell lymphoma. Secondary lymphoma of the breast is more frequently found to be non-Hodgkin lymphoma versus Hodgkin lymphoma. In the images, you can see the area on the top mammogram is denser and brighter compared with the mammogram of the exam in the previous year of the same patient. This is a 65-year-old patient who has known lung cancer and presented for her annual mammogram. The patient felt an unusual area in her right breast. She did not tell her primary care physician, so she went ahead and had her screening mammogram. Mammographically, the interpreting radiologist would immediately know that the right breast needs additional workup from its appearances. The sonographic features of breast lymphoma can be nonspecific. The area can be of mixed echogenicity or appear as a hypoechoic mass. The shape can be oval or irregular. Margins can be circumscribed or indistinct. Orientation is usually parallel to the skin. So here you can see parallel. Lymphomas are usually hypervascular, and lymph nodes in the axillary region may also be enlarged. So we got another one. The patient with Paget's disease, how old was she? She was in her 60s. Yes. All right. Metastases. Cancer can spread through the lymphatic system, the bloodstream, or by direct invasion. This is just an MRI, and here you can see the blood vessels reaching down to it, pulling in, and you can see the lymph nodes are very much enlarged, and this is that tumor here spreading. Metastases from the breast to other areas is usually via the axillary lymph nodes. Cancer can spread to the supraclavicular lymph nodes, those are up in here, which would then indicate instant metastases to areas such as bones, liver, lung, or the opposite breast. Metastases from other areas to the breast are uncommon. Only about 2% of the breast cancers will be spread to the breast. Only about 2% of breast cancers spread to the breast, other breast. The most common include melanoma, non-Hodgkin's, lymphoma, and sarcoma of the lungs or the ovaries. The axilla is the most common place for the breast cancer metastases. Lymph nodes are a normal part of everybody's body. Their function is to drain and filter waste away from organs and tissue. Lymph nodes in the armpit region are called the axillary lymph nodes, and these are the nodes that commonly drain the breast first. Normal lymph nodes can be hypoechoic to isoechoic. So this one obviously is a little bit irregular because the cortex is enlarged. We are looking for a cortex usually that is less than 3 millimeters. Depending on what your protocol in your facility is, you might measure the whole lymph node. In facilities that I have worked across the United States, we measure the cortex, and if it's at 3 millimeters above, that puts that into the concerning or suspicious category, and it needs to be FNA'd, fine needle aspirated, or a biopsy. And if it has any vascularity, again, that makes in the cortex, that makes it a suspicious for disease also. Here's a cine of abnormal lymph nodes. So you'll see them come into play here. Here's some lymph nodes there. And here you can see it's enlarged, lumpy, bumpy. And we've got another one. This is a large lymph node. The hilum is almost obliterated and not even there. So that's very worrisome for spread of disease. I can push that one more time just to look through. Usually we'll use a wide screen when we're scanning our axilla. This is muscle. And so here you can see a lymph node coming in. Here's the hilum, cortex, and you can see it's lumpy, bumpy. We would stop and measure that. Here's another one coming in. So we'd stop and we'd measure that whole thing because we don't see a hilum anymore. When using ultrasound to assess lymph nodes, there are limitations. Microscopic metastases cannot be found. Even a perfectly normal lymph node could have cellular disease. Some lymph nodes that are suspicious for disease, many do not enlarge or change shape. So some enlarged lymph nodes are merely inflamed or reactive and do not contain disease. Therefore, accurate measurements and correct display of the planes of the lymph nodes when imaging is very important. But key to determine the recommendation to establish whether we have a reactive node or a disease node is that cortical thickening measurement. So as long as it's 3 millimeters and over, then we are worried and it goes in that suspicious category for a biopsy or FNA. Something you'll encounter when administering to a patient with breast cancer or when looking at pathology reports is tumor type and stage. When a cancer is assessed to determine stage, the TNM system is used. T is for the primary tumor size, N is the regional lymph node, and M is the distant metastases, if it is reaching that point. Determining the stage of a tumor helps estimate the patient's prognosis, with lymph node involvement being the most important factor. Once the disease has spread to the lymph system, there is concern for spreading beyond into other organs of the body. So the grade of a tumor refers to how aggressive the tumor cells look when observed under a microscope. Grade 1 tumor cells resemble normal breast cells, and you will read in the pathology report the words will say well differentiated or low grade. A grade 2 tumor cells are described as moderately differentiated from normal breast cells. And grade 3 is high grade, more aggressive breast cancer, and the cells will look very abnormal and poorly differentiated from normal breast cells under microscope. As a breast sonographer, it's always important, after you find the target lesion, to scan around the area to be sure that there aren't any extensions or separate smaller cancers. So if it's multifocal, it'll have 2 or more cancers found within the same ductal system or quadrant of the breast. And that would be one cancer that spreads within the ducts, or 2 separate cancers. 2 or more cancers found within 5 centimeters of each other. This happens in 25 to 50% of invasive cancers. They are multifocal. Multicentric means 2 or more cancer lesions found in separate quadrants of the same breast, or both breasts. Worse prognosis than multifocal. This is again 2 or more cancers found more than 5 centimeters apart. So if it's in the same breast, more than 5 centimeters apart, different quadrants, or it's found in both breasts, it is then called multicentric. If it is multicentric, there is an increased risk of recurrence. Hormone-positive breast cancer. So breast cancer tumors are tested for hormone receptors. In these type of breast cancers, when it is feeding a hormone-positive breast cancer, it's either that the receptors on the cancer or in the cancer are pulling estrogen or progesterone in. It's feeding the cancer. It could also be one that's called a HER2 positive. This is also a breast cancer or hormone-positive breast cancer. This one's a little bit different in that the receptors on the breast cancer cell, they become overstimulated and they have overgrowth of that protein receptor. So therefore, it becomes a breast cancer. So hormone positive breast cancers means estrogen, progesterone, or HER2, or any one of those combinations, it could be any or all, are feeding the cancer. So some treatments for that would be some anti-estrogen medications like tamoxifen, some aromatase inhibitors, or chemotherapy and radiation. And that can help to shrink it, to even, in some cases, even obliterate it and get rid of the disease. Triple negative breast cancer, this is an invasive breast cancer. This is the type of cancer where it has none of those hormones. It doesn't have estrogen receptors, progesterone receptors, or any HER2 positive receptors that are overstimulated. It grows and spreads quickly. It's difficult to treat. Chemotherapy is the best treatment. The prognosis depends on the stage and the grade when it is diagnosed. And here you can see this one here. This is a triple negative. And as a sonographer, you'll get used to seeing this type of a breast cancer, or I'm sorry, a lesion seen on ultrasound that looks irregular. It's very hypoechoic. They'd even say markedly hypoechoic. It just doesn't look right. And then when it's biopsied, it'll come back as a triple negative breast cancer. It's an invasive ductal cancer, but it's a triple negative. Here's mammographically what that will look like. Usually lacks spiculated margins, irregular shape and suspicious calcifications may be associated with it. And then triple negative breast cancer can be mammographically occult when it's very small, especially in that dense breast. Sonographically, high sensitivity for the detection of TNBC. Most frequently, presentation is as a discrete mass, well circumscribed margins. Sometimes it'll look like a nice round lesion, but if you look really close, it has some irregular linings of that mass. Posterior enhancement. Why is that? Do you see how there's some enhancement? But this is a cancer. This is a cancer that grows very quickly. So the cells in the middle are actually dead. They're necrotic. So then the sound waves goes through it faster and it causes a posterior enhancement. So this is one of those that kind of goes against those. Again, multifocal, this is what that looks like. A couple of them right by each other. Cursor wasn't working. This is a panogram because this is a very large breast cancer in one breast. So remember, 2 or more cancers found more than 5 centimeters apart, separate quadrants, opposite breasts. This is 7 centimeters. We're probably not even getting the edge of it. So this would be called a multicentric breast cancer. So the sonographer's responsibilities. What is expected from you? Whether the patient is there for a callback and the interpreting physician is looking to correlate mammogram findings, or the patient's there for some type of clinical concern, the sonographer needs to understand the breast and where the lesion may lie in relation to the rest of the body's anatomy. If a lesion is anterior or on a mammogram, then the lesion will be found anterior or near the surface of the skin on the ultrasound. If the lesion is in the posterior third on the mammogram, then the lesion will be at the bottom or very posterior on the sonogram exam. This is one of those. It's very posterior. And this one's in that mid portion. It is very important that the sonographer takes the time to scan slowly and correlate with the surrounding tissue to be sure they are not missing any suspicious areas. If a suspicious area is not seen, then appropriate image should be taken to document that the area of concern is negative. At least 1 o'clock position of the quadrant with both planes should be documented. Distance from the nipple should always be on the images, and the correct breast, left or right, should be documented. Otherwise, thank you everyone for joining me today, and please join us again for future courses. Have a wonderful day.